Morning, good afternoon, and good evening. Welcome to today's webinar, hosted by the IBP Network and the High Impact Practices in Family Planning. Today, we're going to be talking about how to facilitate the inclusion of persons with disabilities in family planning programming, strategic planning guide. Next slide. My name is Nandita Tate. I'm based in Geneva at WHO. I'm Indian American, and today I'm wearing a black shirt. And I'm very thrilled to be moderating today's webinar. Next slide. Just quickly want to go through today's agenda. We have a very exciting program for you today. I'll start with some background on the high impact practices, and then I will turn it over to my colleague Alessandra Aresu from Humanity and Inclusion, who will walk us through the strategic planning guide. Then I will turn it over to her to facilitate a discussion with two speakers, Salma Mahboub and Zakiya Musa Ahmed. And then finally, we'll hear from Diana Carolina Morena from Pro Familia about some of their work. We hope to have some time for question and answer, so please do have some questions ready. You can type them in the chat. Next slide. Before we begin, I just want to remind everybody that the webinar will be recorded, and we will be sharing the recording on the WHO HRP YouTube channel afterwards. We also have closed captioning available, as well as interpretation into international sign language. And you can see it on your screen or use the link at the bottom of your screen to activate the closed captioning. Again, please do submit your questions via the chat, and you can find more information about the high impact practices in family planning on the website listed on your screen. Next slide. So let's get started. What are the high impact practices in family planning? I think many of you are familiar with this effort that was started over 10 years ago as a way to really build consensus around what interventions or practices are evidence-based and really work in family planning. So the high impact practices were developed, and it's really become a set of evidence-based interventions that have been vetted by experts against scientific criteria, looking not only at the impact, but also replicability, scalability, et cetera. And most importantly, these are practices that are documented in a very easy to use format. And the idea is that we can take evidence and package it in a way that helps to facilitate use. Next slide. The high impact practices, and I will refer to them here out as HIPs, have been divided into several categories. So we have those related to enabling environment. So what are some practices that address systemic barriers that affect a person's ability to access services? So these might be things like government policies or finance, things like that. The second group is really around service delivery. So how do we improve the availability and access to family planning services? So these might be practices like expanding community health worker provision, providing mobile outreach services, et cetera. And then finally, the third category is around social and behavior change. And these are practices around, in knowledge, beliefs, behavior, social norms that are associated with family planning. In addition to the briefs, we have enhancements that can enhance the implementation of the various evidence-based practices, as well as the strategic planning guides. And that's what we're going to be talking about later today. If you go to the next slide. Again, really quickly, the evidence briefs, as I mentioned, really help concretely define the practice in a very detailed way and also summarize the evidence of the impact, as well as provide some information on experiential learning and tips for implementation. And you can see a list of the different interventions listed there. Just a point, many of these are not new. Many of you joining us today are implementing these in your programs already. And the HIPs provide, as I mentioned earlier, a really nice way to synthesize some of this evidence and build consensus so that we all have access to evidence around these practices in a very easy to understand succinct way. Next slide. So today we're going to be focusing on the strategic planning guide around how to facilitate the inclusion of persons with disabilities in family planning programming. And we're honored to have a stellar set of speakers today. I'm going to introduce my colleague and friend, Alessandra Aresu from Humanity Inclusion, who will give an overview of the strategic planning guide. She'll then facilitate a discussion about implementation with Salma Mahboub and Zakiya Musa Ahmed. And then I'll introduce our last speaker, Diana Moreno, who will talk about how they've used this guide in their programming in Colombia. So if you can go to the next slide. Without further ado, I'd like to introduce our first speaker, Alessandra Aresu. She is the Director of Global Inclusive Health at Humanity and Inclusion. She's been working in this field for over 20 years and has a proven track record of really promoting inclusive sexual and reproductive health services to people around the world. So we're thrilled to have her with us today to talk us through the strategic planning guide. Alessandra, I'll turn it over to you. Welcome.
Thank you, Nandita, and good morning, good afternoon, and good evening, everybody. Thank you for joining us today. And I'm Alessandra Aresu, and I have long brown hair, I'm wearing glasses, and I have an oval face. I want to first of all say thank you to Nandita for her leadership, really within IBP, but also for continue stimulating the opportunities for us to promote inclusion within IBP. This is extremely important for everybody. This strategic planning guide really is an opportunity to make one step forward towards inclusion in the field of sexual and reproductive health. A topic that step by step is receiving more attention, but that in fact needs the investment, the commitment, and the work of each one of us, no matter if we are organizations and representative of organizations that work on disability inclusion already, or representative of global health stakeholders that are discovering today disability inclusion and the need to work on this subject. Because time is always tight, I want to make sure that we can spend as much time as possible on sharing about this strategic planning guide. We know that you had access to it before connecting because you had a link that is already on the HIPS website, but we want to make sure that you have in mind some of the key elements that we want to highlight before getting into a discussion. And so if we can go to the first slide, and thank you for moving the slide, we would start reminding ourselves what is the objective of this specific objective of this document. Is really to guide program managers, planners, and decision makers through a process that will help the inclusion of persons with disabilities in family planning programming. And this is really the aim, because the strategic planning guide was developed really with the purpose of supporting those who find themselves in the process of wanting to include persons with disabilities, as it should, but find themselves without tools, without enough experience, and that needs to do the first few steps. Of course, there are other documents that are larger that have been produced, but this is really a first step for all of you. And the strategic planning guide was developed through consultations and discussion with organizations of persons with disabilities that we often refer to as OPDs or DPOs, with service providers, with technical experts in inclusion, family planning, and sexual and reproductive health and rights. And we know that some of those who have helped us really in frame this document are on the line. So I take the opportunity to say thank you to them. And while we need to speak about this today, still, despite the fact that there is some work already done by many of us on disability inclusion in the health sector and in SRHR, is because, in fact, today, still persons with disabilities, and especially women and girls, do not have the opportunity to access sexual and reproductive health and rights information and services. They face many barriers, and they belong to a group that we often refer to as those left behind. However, we have to keep in mind that persons with disabilities is never an homogeneous group. So every time we work also on this specific population, we need to keep in mind an intersectional perspective that remind us that there is that persons with disabilities in all their diversity need to be introduced to, need to participate and to share what it is important to understand about themselves in their full identity. As the women, as young people, as persons with disabilities, because disability do not define individuals on its own. And so it is important really to discuss with them, exchange, and have them with us step by step. And this is why today we really want to expand this discussion. Now, we are also very lucky because we have now a big frame around us, that is the WHO Global Report on Health Equity for Persons with Disabilities, that really promote health equity for persons with disability overall. And therefore, there is a bigger document that help us to place inclusive SRHR in a bigger framework. And if you did not see it, please refer to it. It is online on WHO website. Why so many people are moving towards disability inclusion and raising the flag of disability inclusion in the health sector? Because we need to remember that more than 1 billion people have a disability or multiple disability in the world. 1 in 5 women, 1 in 5 are women, and therefore it is 1 in 5 women are women with disabilities, and therefore there is a need really to ensure that we work towards inclusion overall. Because as we said, a lot of women with disabilities and overall persons with disabilities are excluded from SRH information and services, but also are more likely to experience physical and sexual abuse, and among other types of violence and abuse. And also they are often subjected to forced or coercive procedure within the family planning services, such as sterilization, abortion, and contraception. And so this is really important. I would move to the next slide so that you can see and we can remind you about the content briefly of this strategic planning guides. First of all, we refer to 5 key essential actions that ensure family planning services are inclusive of persons with disabilities. We will go one by one. But before getting there, we want to remind ourselves that there are principles of inclusive family planning programming that need to be kept in mind all the time. That is, they are directly inspired by the CRPD, the Convention on the Rights of Persons with Disabilities, and they are accessibility, participation, non-discrimination, meaningful participation of persons with disabilities throughout all stages of planning and programming. And of course, because often it comes to mind about persons with disabilities a little bit at the end of the project or in the middle of the project, and that will bring a lot of challenges and will not promote meaningful inclusion as we want to promote here. And so when we are talking about key actions, the first one is really the very first step is collect information on disability and sexual and reproductive health and rights. So we know there are data out there that are not always known. And so if you are planning to have a project that is inclusive, as we promote during this webinar, please make sure that you identify the data that are already existing, in terms of the situation of persons with disabilities in your country, understanding the policy that are available on family planning. Are they inclusive of persons with disability or not? Which organization of persons with disabilities are in your country or in your area? Which kind of information are really needed to design a project? Are there disaggregated data by gender, age, and disability on family planning? If not, how can we really identify those data that will be essential to design a project that is inclusive? The second key action is ensuring participation. So ensuring participation, developing meaningful cooperation, and build in meaningful partnership with persons with disabilities and their representative organization is at the core of any project that is inclusive, which means really that together with persons with disabilities, we can identify and address barriers from the very first step of the design phase of the project, based on the principles of nothing about us without us, which is really a mantra that we want to promote always. The third key action is identify and address key barriers and facilitators to ensure the access to family planning information and services, and also to ensure the quality of this information and services, and to ensure that we fulfill the right of persons with disabilities. And so today with our guests, we will really talk about what are barriers, what are facilitators, and how this can be identified and addressed. We will hear from them, but just to anticipate that there are many types of barriers: attitudinal, physical, communication barriers, institutional barriers. But I will not anticipate a lot because we will talk about this with our panelists. And of course, we will also hear about what does it mean working through a twin-track approach that is needed to address and remove barriers. And if we can move to the next slide, we can also see the other two key actions. One is related to budgeting. The disability inclusive budgeting is core to our work on inclusion, because if we don't plan in advance the resources that are needed to develop and design and develop a project, as for any other aspect of each project, then we will not be able to promote an inclusive project and design and implement an inclusive project. And so allocating enough resources from the beginning is essential. And of course, also making sure that we have set indicators to monitor the allocation and the use of that budget. And the last key action is to really put in place and monitoring, evaluation, and learning mechanism to collect data on the access of persons with disabilities and to quality SRHR information and services. Of course, the gap in terms of evidence is immense. And so to our project, not only we promote the right of persons with disabilities on SRHR, but we also contribute to collect data, to analyze data, to fully disseminate data, and in the end, continue to collect evidence for further advocacy in the future. And I will really stop here because time is really limited, and I want to take the opportunity to have as many minutes as possible with our panelists and then have your questions. So I would like to call our panelists, and please, Salma and Zakiya, turn on your camera so that you can be next to me, even if we are not around the table together. And I have really the pleasure to introduce the first panelist, that is Salma Mahbub. She is the founder and General Secretary of Bangladesh Society for the Change and Advocacy Nexus, a woman-led DPO in Bangladesh. And the second panelist, and please, we can see the second slide, is zakiya Musa Ahmed. She is now a colleague in HI, inclusion officer at HI South Sudan, specifically for the Women Integrated Sexual Health Project, but she's also an activist and a woman with visual impairment and a leading voice of the South Sudan Women with Disability Network. I will keep the introduction short because I want to make sure that they will say more about themselves when they have the floor. And without me really saying too much about themselves, because the presentation of themselves is the best way to know them one by one. And so I would like to start with Salma. And Salma, the first question is for you, and I wanted to ask you, as we know, Key Action 3 really discusses the need to identify and address key barriers and facilitators. You have all heard me. And so I wanted to ask you, could you, from your experience in Bangladesh, share with us a couple of examples of key barriers that women with disabilities face in Bangladesh when it comes to SRH services, particularly? And thank you, and I will pass you the mic.
Thank you, Alessandra. Good morning, good evening, and good afternoon to everyone. I am Salma Mahbub. I'm working in a disabled people organization called BSCAN. I'm working here for 13 years. The topic that we are going to discuss today is very important. And as you know that in Bangladesh, mostly parents arrange the marriage of their son and daughters. As a result, in most cases, no initiatives are taken from the family for persons with disabilities, especially women with disabilities, for getting them married, because they think, who will marry them? How is it possible that a person with disability can marry or have a child? Especially when it about women with disabilities, it is seemed more impossible, because in here, most men wants a perfect wife who can run all the works for him. So they think it will not happen with the women with disabilities. They think women with disabilities are not normal. They cannot have baby, etc. This kind of thing goes in their mind. So you see, there is a lack of knowledge and awareness, lack of information and ignorance about SRH, and importance of sexual rights is largely ignored here. In fact, there is a myth that persons with disabilities are asexual or less sexually active, therefore less likely to have SRH needs. Even though some men and women with disabilities get married, but in the field of family planning, especially women with disabilities are not given much thought. Women with disability during pregnancy, especially if she has mobility or vision or hearing disability, it becomes a very difficult time for her because of our health system is not disabled friendly. From doctors to hospital infrastructure, various medical equipment, transport system, which is not conducive to them. The hardship increases even more for a woman with disability in the rural area. Community clinics are not nearer to their houses. They need to deal with a lot of stigma, misconceptions, and adding to that, women from hard to reach area, we cannot imagine the difficulties they face because they don't have the voices either. It is very sad that after 52 years of independence, we still do not see much disabled friendly toilets in the hospitals. Even in the renowned hospitals as well. I know a woman who admitted in hospital during her pregnancy but could not go to the toilet just because there was no high commode. She was a spinal cord injured wheelchair user. At last, uh, at last she had to go to her home for the toilet, then came back again. Through her, though her home was not nearer to the hospital, it was a hell of a situation for her. We know these kind of stories a lot. Most of the time, the doctors get surprised when they see a pregnant woman with disabilities. They even shout at them why they had taken this burden. They still cannot accept the motherhood of a woman with disability. They see it as a challenging task rather than it's her rights as well. It means that our society is still not able to take family formation of women with disability easily. But there are exceptions as well. Thank you.
Thank you. Oops. Thank you very much, Salma, for sharing so much from your experience in Bangladesh. It is extremely important, and I believe many people on the line may have experience in working in Bangladesh, and what you have shared can be very inspiring for them. And please keep your camera on because I would like really to make sure that colleagues on the line can still see you while we move forward with the second question that in fact I would like to ask to Zakiya. But it's as we cannot be in the same room all together, it's nice to be in the same screen all together. And so, Zakiya, first of all, welcome also to you, and please introduce yourself. But after introducing yourself, I have a question for you. The question is the following. We know that from the strategic planning guidance, the key action 2 refers to the importance of ensuring really meaningful cooperation with the organization of persons with disabilities. And Salma has described to us some key barriers for women with disabilities to access sexual and reproductive health and rights services in Bangladesh. What I would like to propose you is for you to share really about your experience in South Sudan on how cooperating closely with the organization of persons with disabilities can really help addressing these key barriers and identify facilitators, knowing that you are very active also in the community beyond the work that you do with HI. And so I'm happy to pass you the mic, and thank you.
Thank you so much, Alessandra, and thanks for the organizers. But before, I don't know if I've really been seen because I tried to start my video here, but it's telling me that the host is already stopped my video, so I can't access.
So for now, Zakiya, thank you. We cannot see you, or you are not spotlighted, so give us a moment to see if we can fix the video's problem. Maybe I can ask the colleagues that are working very hard behind the scene if you can help us in bringing Zakiya video on the screen. And here you are, Zakiya. Now we can see you, and the video is working, so please go ahead. The floor is yours. And please, Zakiya, you are muted. So if you can try to unmute yourself again, because again, we may have a problem also with the mic. Try
Hello?
now. Yes.
Yes?
Perfect. Please go ahead.
Thank you. Thank you. Thank you so much once again, Alessandra. And my name again is Zakiya Musa, and I'm a visual impairment lady. I actually wearing a free African dress, which with blue color, and yeah, much of actually brief of my introduction. Just to go on through the question, yes, of course, here in South Sudan, we are actually working very hard to make sure that OPDs implementing our activities as HI and especially in WISH program, because we need to consider the aspect of nothing for us without us. And that's why the participation of organization of persons with disabilities, it is our key element. So I just want to highlight some 4 key elements, if my time can really allow me to explain it a bit. The 4 key elements that is really helping us to cooperate with the OPDs here in South Sudan, it is, one is the consultation, and then the information, and the third is the engagement, and then the lastly is the involvement. And we need to make sure, and actually the last element, it is a very important element. This is where the aspect of nothing for us without us come in, because how to address these barriers that was mentioned by my colleague Salma in Bangladesh. We need to really inform OPDs about the project, the activities that we need to do, if in terms of project. And that's why when WISH project came in, we come to the OPDs and we told them that this is project in WISH, and this WISH, of course, WISH is Women Integrated Sexual Health, for those who maybe doesn't have idea on WISH. So we told them that this is WISH project, and the area of the focus of this project is going to mainly focusing on inclusive sexual reproductive health services, whereby there is some barriers that hindering your participation in getting these services, or maybe some challenges, but we don't know, because they are the very people who knows more on which kind of barriers that are facing them. So we inform them about the project, and this is how we are going to work, and this is how we need them to give us their say. And that's why when they are well informed, they came with the information, whereby during the consultation meetings, we make them to take place in how they can be able to feed us with how we can be able to address these barriers and how we can be able to remove them. And this is the area of consultation. Assessment, we assess their gaps. We assess there is no inclusivity into SRH services. There is a lot of discrimination for them to go for these services, a lot of stigma for them to even go to health facilities from the service providers, attitudinal barriers that towards them. So all this, when we are able to do the barriers and facilitators assessment with them, then we told them, now, of course, now you are the one who knows more on your activities, then why not to be engaged, to take part in this project? And that's why the issue of engagement came in. They have to know that they are really engaged with such kind of task, and they have to do it. And that's why we because we have many OPDs here in South Sudan, so we cannot be able to work with them individually, so even differently. But what we do, we united them. And actually in the aspect of engagement, we need to build their capacity, and also tell them, or maybe to remind them on how they can be able to unite, because for you to achieve one goal, you have to make sure that you have to, because one hand, we have a say that one hand cannot clap. When you join the other hand, then 2 hands can clap. So this one, actually, it's whereby we combine them, we give them, we form a group called WISH Task Force Team. This is where we have been able to achieve this goal, addressing these barriers and coming with the facilitators. Now, nothing for us without us came in, whereby we gave them tasks, because we don't want them to participate as a representative, or rather to take their pictures and write their report. Yeah, this is program we do for persons with disabilities, and these are here. So now the donors, even when they see the pictures, yes, of course, this is the program, and this happened, and the collaboration is very well through the pictures. But we need to make sure that, of course, when we are taking their pictures, while they are facilitating activity, like now, right now I'm talking, you see, while they are interacting with the community, informing them about the SRH services, and yet their pictures are taken. We don't want to we don't tolerate the issue of taking pictures and somebody with disability or with impairment is just seated in the chair. No, we want to give them tasks to do, so that their capacity and their ability is really shown to the people. hope I'm not taking time. Thank you.
Thank you, Zakiya. There is so much that each one of us want to say, that the most challenging thing is to stay within time. So you are not the only one to be really trying to say a lot, but let's try to remember to speak slowly, because we have the sign language interpreter who needs to be able to do the interpretation. And Zakiya, please keep your camera on, because I want to ask you, and in this case, to spend only maybe 1 minute, maximum 2, if you can, to tell us a few words on the meal mechanism. We say the monitoring and evaluation and learning mechanism. Can you explain to us your experience in South Sudan of putting in place such a mechanism? And in this case, because we need to give the floor to the next speaker, I really ask you to take only 1 minute in this case, just to give us a sense. And then all the audience can come back to us with questions, and we can explore, we can refer them with to documents that can bring them in a more deeper context of this mechanism. But please go ahead.
Okay, thank you so much. Actually, as I said earlier, we have to make sure that OPDs are well participating in our program and they are well informed. So now the issue of meal mechanism, this is where, because we have two things here we need to consider. First of all, the monitoring, whereby we need to monitor now, because before we have been doing with them, we have been cooperating with them, and even they are our co-designer when we are designing activities. And if we are, for instance, if we are doing dialogue, maybe they will be the co-facilitators. But now they are the really people who will be in front of facilitating their activities by themselves. And for us who have been before, guiding them, we are now will take the back seat, whereby we can just monitor them from far. So it is actually the area of monitoring whereby we give them tasks to do by themselves and to write for us a report. And this is where we can be able to prove that, okay, these people, they have the capacity and they can be even to be given grant to do their activities by themselves, because they prove it a long way by themselves. So this is the issue of monitoring. Then evaluation, of course, together we can come with them as we have been cooperating. We can come with them and sit down how we have been able to see the good positive part of this project, and then the bad positive and negative part of this project, because this one actually can make us learn. And this is the issue of learning actually will come in that in the new next intervention or maybe next activity, we are going to learn from the mistakes that we have been able to identify during the feedback mechanism that we have been able to identify with them. So, and that's why actually we train them even to know about how they can be able to introduce the Washington State Group of Questionnaire, whereby this kind of assessment tool can help them to identify persons with disabilities for them to get a very good quality services. And even we make them, they are the one to train the service providers to make this if their tool is not inclusive, then they have to integrate this Washington Group of Questionnaire into their tools, so that they can be able to assess persons with disabilities, not just do you have the number, or do you have disability, how many numbers of persons with disabilities. Now these services will just remain as a quantity, but it will not reflect the quality, the disaggregated data. So it is persons with disabilities, we make them to train other service providers on how they can be able to use this Washington Group of Questionnaire to identify the quality services for persons with disabilities, and even the disaggregated gender, age, and disability for them to be into their program. So this is what I can just say briefly about the monitoring.
Thank you.
And evaluation.
Thank you so much, Zakiya. And my last question is for you, Salma. And again, we only have 1 minute before passing the mic to our colleagues, but you have shared a lot on the challenges that women with disabilities especially face in accessing family planning services. Can you give us one good example that you have witnessed on how women with disabilities have been included to live this panel with a very positive message of how this can happen in reality. And that is inspire everybody. Salma, we cannot hear you. Can you please double check your mic?
Sorry.
Thank you. No problem.
Okay. One good example I can give you, that national policy that we have, national health policy. There, Bangladesh government has mentioned about women with disabilities in the principle and also in the activities, strategies. So in the National Adolescent Strategy 2017 to 2030, also mentioned about adolescents with disabilities in several places, and also SRHR is also mentioned there. But in the National Strategy for Maternal Health 2019 to 2030, there is only one place where disability is mentioned, where they talked about obstetric fistula effects. So I think it's good that health policy has mentioned about women with disabilities, but I think other policies should also include women with disabilities. Another thing I would like to say here, that the National Maternal Strategy included the CEDO, CRC, but they didn't mention about CRPD. So if they would have mentioned CRPD, automatically women with disabilities would have been included there. So I would like to say to the other countries, whoever they are building the policies, making the policy, they should include the CRPD articles there. Thank you.
Thank you, Salma, also for being able to be brief. We know that Bangladesh has a good document that could bring as an example to others. So anything you can share in the chat with our colleagues on the line is very welcome. And as a reminder, the CRPD is the UN Convention on the Rights of Persons with Disabilities. And I'm reminding us this because not everybody on the line is an expert on disability inclusion. And with this, with a little bit of delay, I pass the mic to Nandita again, and I thank everybody for listening and our panelists for presenting. Thanks a lot.
Thank you, Alessandra, and to our speakers for that engaging dialogue. I think for me, who is not an expert in disability inclusion, I think it was very eye-opening to remember and see how complex and diverse these issues are. The other takeaway I took was really important to plan ahead and really think about resources needed to support this work. And finally, and most importantly, how do we all institutionalize this in all of the work we do? This shouldn't just be a one project or one organization responsibility. It should be the responsibility of all of us working in family planning and sexual reproductive health. So thank you all for that. I'd now like to turn it over to our final speaker, Diana Carolina Moreno from Pro Familia Colombia. She's the Director of Advocacy for Pro Familia Colombia and is a researcher and teaches gender and human rights, an expert in SRHR, a friend. And I just want to note that in addition to sharing their experience implementing some of this work, Pro Familia was also a winner of the IBP Implementation Stories contest last year, where they highlighted some of their work on disability inclusion in their implementation story. So congratulations again to you all, and Diana, the floor is yours. Welcome.
Thank you very much, Nandita. Thank you for having us here, to all the colleagues of IBP and also to Humanity Inclusion colleagues. Since we're running a little off of time, I'm going to try to be very brief to just share our experience in working on sexual and reproductive rights of people with disability. As Pro Familia, we are a member association of the IPPF in Colombia, and we regularly provide sexual and reproductive rights services. But it was only till 2012 that we actually start asking ourselves about how to do this inclusion of people with disabilities. In Colombia, it is estimated that around 4.7 million people are people with disabilities, and out of this percentage, 51%, around that, have reported having encountered barriers to access health services. Specifically when it comes to the intersectionality and loop to reproductive rights services, we have found that there is a lot of this denial of their sexuality that comes with the dynamics that Selma was talking about, the idea that people with disabilities do not have an active sexuality, nor they deserve it, and also, or a family, and also sometimes a totally opposite and contradictory idea of people with disabilities being actually over-sexualized, even to a point where some people might consider them dangerous. Either of these ideas that are wrongful and misperceptions can lead to different sorts of stigmatization, discrimination, and also violences within the health system and provision. Next slide, please. When we realized this, we started, just as our colleagues were mentioning, by creating data collection in our own private system, in our clinics, 53 clinics around the country, to understand who was coming to our services and how we could adequate them better. And we also partnered with civil society organizations, with people with disabilities, and organizations of families of people with disabilities, in order to understand their perspective, their needs, and their barriers when coming to our services. Out of this process, we restructured our attention process for people with disabilities. We created general recommendations that were included for every time we were to work with people with disabilities, especially those people who had a psychosocial and cognitive disabilities, because we identified that in the terms of sexual and reproductive rights, there was where was most common to believe that people with disabilities did not have the right to choose, and where they were experiencing dynamics as forced sterilizations, forced contraception, and higher rates of sexual violence. Some of these general recommendations that I would like to highlight for you may sound very simple, but are quite very important. Just as actually doing eye contact and understanding for providers that the person you are providing service to is the person with disabilities and not their families, their tutors, or anyone around, even other health professionals. Also, the importance of being able to use simple language, to be always aware of nonverbal communication, and to be able to integrate different ways of sign language services into your consent provision or information provision. These, depending on the country, can vary, but for us, there is a big center of sign language from the state. So what we did was we create an agreement between us, so that every time that someone might require the service in our medical consultancy, we are able to connect online and provide sign language interpretation if needed. We also have in mind that it is important to extend the time of a consultation, because professionals need the time to be able to value the needs of adjustments and support, to be able to implement this, and to be able to even talk more simple, or be able to re-explain some of the issues that they are trying to communicate through. So many times we have limitations around the time we have for providers to interact with patients or users. Then a big important part is to be able to extend this time when we are talking about people with psychosocial and cognitive disabilities. And we also created a special process of informed consent. More than a special, I'll say that is a specific way in which we ensure that it is the consent of the person with disabilities, the one that we are taking into account as health providers, and that we are actually working to obtain. What we have is that we have a tool that allows a provider to be able to identify the different needs for communication, adjustments, and support that a person might need when understanding information. And after that, having a set of kit tools that can be implemented in consultancy to be able to use. That goes from images, color paint, guidelines for professionals to be able to have simpler language, or other sort of guidance of support when we are actually having the support of some family members or some people who know the person we are providing attention to make sure that we are able to get our message by and also to get the consent. Many times this cannot be done in just one consultancy. So sometimes we do even 2 or 3 appointments to be able to end the proper process of informed consent. Only in a very extraordinary scenario in which all the efforts have been done in order to acquire informed consent with reasonable adjustments and supports, we have an extraordinary process that is called assisted consent, in which we have sort of like interdisciplinary committee that is composed, first of all, for the person or user we are working with, and also different professionals that might be related to their care, and some of the people of the support network that might surround this person. And there we discuss not what is it that we think is better for them, but out of the information that we know from them, how we think they would have taken this decision. And then that would be the way the decision is made in a last ultimate emergency, ultimate resource sort of way. But bigger most of the time, we are able to get informed consent just out of being able to evidence the support that people need. I want to highlight here that our work is not only within the health provision work. We also have expanded our comprehensive sexual education processes in an inclusive way for people, young people, both with and without disabilities, which has proved to be very impactful for all of the assistants. And also, we have understood that there is an importance of being able to replicate this model in a way that is also national and that it impacts legislation, because in many of our countries, we're still not complying with higher international standards. For example, the Convention of People with Disabilities around legal capacity and around health provision. So as providers, we also can have a big important role in order to let decision makers know that our experiences around providing adequate attention to people with disabilities and taking into account their own perspective is the most important thing we should do. Please, can we just go ahead to lessons learned? So ultimately, I want to tell you that from our experiences, we have learned that listening to the voices and the desires of people with disabilities around sexual and reproductive health requires a continuous development of creative and innovative communication and education strategies. As Selma, Seika, and Alessandra have mentioned, the importance of partnering with civil society around being able to create these strategies. The inclusion of planning is key. And here, just adding to what my colleagues have said, I just want to say that it is not only important to plan for the service provision, but for actually everything we do. How is our communications? How is our infrastructure? How are other sort of programs that are not service provision, like education or advocacy, also taking into account how they're going to be structured to include people with disabilities? The preconceptions that sometimes health professionals have, or also our staff have, requires the continuous training of everybody. And finally, when it comes to service provision, as I was mentioning, we could have a big role in advocacy efforts. And that might be some of the opportunities that we might be missing when we just focus on service provision without engaging with some of other stakeholders in the universe of the health system. Thank you.
Thank you. Thank you for that presentation, Diana. Some really great work that you all are doing and some really concrete lessons learned. I know we are short on time, so I think we're going to skip the Q&A, I'm sorry to say. But before we close, the presentation and the recording will be available on the site listed on your screen. If you do have questions, I can suggest if you can quickly put them in the chat, we can share them with the speakers and also post a list of the answers and responses when we post the slides. With that, I'd like to thank all of our speakers for your hard work and your time today to share your experiences working in this space. I think it was certainly eye-opening. I think as Alessandra and Zakiya and Salma and Diana mentioned, this should be part of all of our work. And I do look forward to all of us working on this more together. So thank you again for your participation today. I also want to especially thank our interpreters for the interpretation into International Sign Language. We know it's not easy, and we thank you again for your support. So with that, thank you everybody for joining us today. Please let's be in touch and stay tuned for the next seminar series. Thank you very much, everybody. Bye-bye.